channel and taking the time out of your day to come and meet with me. For any of you who do not know who I am, my name is Sue Lady, also known as Sue Lady VSG on all social media platforms, YouTube, Instagram, and Facebook. As all you know, I had VSG vertical sleeve gastrectomy done March 8th, 2019 with Dr. Salcedo at Pompeii Surgical in Tijuana, Mexico. Today, I have the privilege of interviewing one of the leading doctors, surgeons here, Dr. Quinones, and he has been gracious enough to give me his time, which I really, truly appreciate, so that he can answer the questions that you guys have actually sent me. Now, all these questions are all questions that either are coming from past patients who are thinking of coming on over to Pompeii, or people who are already scheduled with Pompeii. It's coming from your private Facebook page. Okay. So I'm really excited to get this started. First, I want to kind of just have a little introduction for you and tell me a little bit about you. What made you want to become a bariatric surgeon?
Well, I'm a general surgeon first. I'm into minimal invasive surgery. Did a lot of trauma surgery for a number of years. That kind of leads you to it. It's a very, very nice field. I mean, you help a lot of people. There's a lot of surgeries that a lot of people don't want to do, and surgeons that don't want to do it. And there's people who need the surgery, so that's kind of a logical thing. A lot of people don't want to do BMIs of 60, 70, or 80. They're comorbidities, and 20 years ago, nobody wanted to do that. A lot of people didn't want to do that, and they don't want to get into that kind of a trouble, and so it kind of led into that. Yeah.
Amazing. And can I ask you, in the field that you're in, which is bariatric surgery, what would you think would be your biggest takeaway or your favorite aspect of, or the most gratifying part of bariatric surgery?
Obviously, successes like yourself, it's really nice, but the bottom part of this is you like that particular part where you really save a patient's life. I mean, patient that was near or rank patients who have on a transplant list and they can't get into the transplant until they lose weight. Patients who are on hip replacement, knee replacement, they cannot do it until we do something about it. Or patients that somebody didn't want to help them, and we could help them. So that's really nice. I mean, that's the part of it.
It's amazing.
Yeah.
Now, a couple questions before we move on to the questions that your patients or possible patients have asked. If there is something that you would like to tell a person who is thinking of getting bariatric surgery, or is even scheduled, what is something you can tell them, like a message that you think that would be good for someone like that to hear?
Well, even if they're not our patients, that research their surgeon well. I mean, have them do a soul search if this is what they want to do, if this is what they feel is right for them, because it's important. Not just get pushed into it or be led into it. If this is what you need to do or want to do, that's really important. This is a personal decision that a lot of people kind of make it with a whole other group of people, but not conscientiously on their own. So getting the upper part of the mind part right. That's really important before doing anything else. But that's it. I mean, there's a lot of aspects to this, but being sure of yourself and what you want to do, that's really important.
Absolutely. Yeah. All right, so if you don't mind, we're going to get into the portion of the questions here. So Sarita asked, why don't they take a picture of the pieces of stomach they take out so we can see how much was cut off? Also, what do they do with the piece of stomach? I think of mine all the time. I abandoned it. I feel like a bad mother. Well, I'm joking, but Sarita, actually, I think you mean this question. So
no, a lot of people
ask. It's a good question.
Well, so filling it up with air, it's a little bit of a showmanship thing. All of them are going to look big if you fill them up with air. You take them out as small as possible so they fit through the smallest incision possible. they see it on the video, so we thought it was not necessary. Sometimes we don't have, and sometimes we're busy and we don't have the personnel to go and fill it out when, because most of the time it's really busy in the OR. That something's bleeding or something has to, you can do it once in a while, but not every time. For it's merely sometimes pleasure of the people that just want to see it inflated for some reason or another. But it could be done, of course, but it's kind of difficult sometimes. What do we do with them? Well, that's a technical question. We actually, biohazard comes and picks them up and take them away, and they dispose of them properly. If his stomach is in any way, shape, or form doesn't look right, we send it to pathology. That's what, everything you take out is supposed to go to pathology, but that's a lot of stomachs that go to pathology. So unless it's something that needs to go to the pathologist, we'll send it. The pathologist is the guy or the doctor who examines tissue, so it looks right or not, cancer tissues or inflammation tissues, whatever it is. That's the pathologist. So if it needs to, we will send it to him to be examined. Yeah.
So you do a lot of revisions, correct?
Yeah, we do. Yeah, we do a lot of
Heidi would like to know, going from a sleeve to a bypass revision at 340 pounds, how much weight should I expect to lose by following the post-op food guidelines?
Okay.
And it varies for each
That's
patient.
a very good question. It's bypass by itself should be about, and this is not just me talking, this is excess weight loss. It evens out, it's a little difference between sleeve and bypass. But for some reason, and it depends on who did the sleeve sometimes, and it depends on the type of patient and type of metabolism, a patient won't lose enough weight with the sleeve, so we'll go for a revision. Usually those cases I will, and this is still not the answer to the question, we'll go a little longer on the bypass on these patients. Now, how much would be expected? I will expect it to go as much as they would lose if I would originally do one, about at least 60% of the excess weight, at least. Again, you never can tell. It can go as far as 80 or all the way to what the patient wants, but at least it's 60%, which is a really good.
Pretty
Between
good.
60 and 70% of excess weight, that's a really good ratio. I mean, that's success.
Absolutely.
Medically, it's a success. I mean, people don't see it as that. See it, well, I want to lose, I don't know, the rest of it, but medically, it's a success. And if it takes away your hypertension, diabetes away, if it takes away knee problems, hip problems, joint problems, if it takes away that, I'm more than happy.
Yeah.
So people don't realize that this is, most of the times, it's health-wise. It's not just, and I'm glad that people look good and they're happy about it, because that's what it's all about.
And it's all about being healthy and being able to live a longer
But if it's happier, if it's healthier, I'm glad with that. I'm happy.
And just if I can add, because she did mention in a person over 300 pounds, just to take myself as an example, I was 311.8 pounds, and I'm 139 pounds now. So I've lost over 172 pounds in a year and 4 months. And of course, that's different for everybody. Weight loss is a custom. It's a custom job for everyone.
And that is also personal, because after a while, it gets to be your job. The first few months, it's the surgeon's job, and it'll do his job. But after a while, it gets to be a little bit of your job, and then after a year, it gets to be your job. Then after the second year, it gets really to be your job, not the weight loss.
To be disciplined and to
exactly.
make sure you have.
So it is.
Yeah, because the surgery at the end of the day is not going to be the cure to all. It's going to be a tool that you use opposed to a cure.
Exactly.
Absolutely.
All
right, so let's see here. Well, this is not a question, but Vanessa just
those patients do really well. Revision surgeries from the sleeve to bypass do really well.
They do really good. Well, I'm just going to add this in here. I know it's not a technical question, but Vanessa Anderson says, please tell him how much we appreciate all his time, planning, heart, and sacrifice that goes into this business. We are also incredibly thankful, and also wondering what he would be doing if you weren't a surgeon. What would you be doing as a career?
Probably, I like cars, I'm probably an engineer.
Oh, ingeniero. An automobile engineer?
Yeah, probably.
That's great.
Do something like that.
All right, so let's see. If a patient is on blood thinners, does this eliminate them as a potential patient?
Not really. No, we have to talk with their doctor, see what the blood thinners are for, see if he can take them off or just do IV blood thinners while she is here. We have to kind of coordinate with our doctor. Most doctors are compliant. If the patient needs a surgery, more physicians are very compliant and they will do. And we'll coordinate here with our internist and with the doctor back home, and we'll usually commit it to
Figure it
that.
out?
It's not a
It's not a end all be all break. It's not one of
it can
those
be
things.
done. No, it's a we call it indication and counterindications. So usually counterindications are it gets to be very few. In the past, if you were 60, we wouldn't do the surgery. If your BMI were below 35, we wouldn't do the surgery. Nowadays, it's not accommodating, and I'm saying it not by any means accommodating to every patient, but you have to accommodate to what it's been done. It's been safer throughout the years now, so it's a lot easier for us to know what we can and we cannot do. And a lot of physicians are now, accepting this as a method. So it's easily done, and you can find it anywhere if it's contraindicated in any guideline that you can look up on the internet, and as you find that it's not a counterindication. You can do it. Yeah.
Okay, so Whitney asks, should you go to your primary care physician prior to having surgery for labs, or all labs and blood work be taken prior to surgery?
We will take so you have to understand that for us it's a little difficult sometimes because we have an idea, but we haven't seen a patient. We get a lot of information, but sometimes there's information that patients omit to tell us. Mm-hmm. And sometimes they get here and blood levels are low or blood sugar is too high. It would be recommended if they can do it a few months before, so that we know what we're dealing with. Usually they have time to fix it, because it's kind of hard to fix it. We usually do try to fix it when we see the patient, or we delay a surgery a day or two if needed, or we don't do it if it's absolutely necessary. But it would be appreciated if patients did it, at least 2-3 months before, because at least we kind of know. A lot of patients nowadays kind of go to the physician regularly, so it's not absolutely necessary.
Can I give you an example, and you tell me if this makes sense? For example, a person who's diabetic who has A1C levels that are extremely high, that would be a good example.
An 8-9, okay.
So let's say you would say about an 8-9 would be comfortable to be done.
No.
Would this be a good case where having blood work done earlier would be better, or?
No, we'll still do the surgery.
Okay.
But those patients are usually under medical supervision, so they usually have blood work. When patients are diabetic, they usually have blood work.
Is there
done.
a circumstance
Yeah,
where
they
maybe
usually,
the patient should have, like for example, you say there's always situations where you can work with the patient and whatnot, but is there particular issues in someone's blood work that would make or break them having the surgery if they hadn't gotten the blood work done prior?
There's very few.
Okay.
We can think of a few. Levels of anemia incredibly so low that we can't even fix it with a blood transfusion. Sometimes a lot of patients come here with very below levels, and we have to fix that, or we have to do a blood transfusion, which is safe and everything, but still preferably if the blood levels were at their normal. There's very few things that we can actually don't take into consideration to doing the surgery. Yeah, but it's as you mentioned, those patients, most of our patients are usually seeing a doctor regularly. So it's almost doesn't become an issue. There are people who really kind of want to do this out of a whimsical, out of I'm going to do it, and it's fine to say, well, they decided to do it, but most patients are at least research us for 2 years or research something, and they don't just come in because they wanted to do it the day before. So it doesn't get to be, but it's appreciated if they do see a physician for at least 2 months before surgery, so we can actually, make it safer and make it
Yeah, absolutely.
Easier for us. There's tumors that we wouldn't perform surgery. If you have a tumor large enough, if it's benign and won't interfere in the surgery, we still can do it and have that taken care of on a later date. Sometimes patients are suffer from epilepsy and they do not tell you we have a case. And those cases are difficult to manage. If you don't have it under control, then you think that's, there's things that patients omit to tell us and once that happens, that all bets are off, all responsibilities about. If you omit to tell us something, it's pretty much lying to us. If you omit to have a condition that you knew you had and you didn't tell us, and it's not, sometimes they're not catchable until you're actually going to do surgery, and that is, that's one of those things that it can be. Neurologic conditions are the most common ones to admit. Lung issues, usually we have, most patients that have lung issues, we can actually take care of that, or at least if they're not chronic, because sometimes the most common ones is sleep apnea, and just by, we have a pretty good idea before they come in, and we can make them do, if they don't have access to medical insurance and they cannot access to CPAP machines and everything, we can have them on exercises and a few days here without shift. That usually helps. Okay. So we don't have a lot of problems with those patients while they're doing surgery. And once they lose weight, usually it gets better, so it's not a big problem afterwards, of course. Yeah.
Okay.
All right.
So Kay asks about the mini bypass surgery. Can you shed some light, a little bit more information on the differences of a mini bypass versus a regular bypass, and how effective it is for type 2 diabetes, and do you do Roux-en-Y? Okay,
yeah, I do Roux-en-Y. We do the mini. So the mini bypass it's a bypass. It's for the most part, it's called single anastomosis bypass out. So not to call it a mini, the reason that they started calling it mini is because it has less surgical parts than the regular Roux-en-Y, and thus less scar tissue and less possibilities of occlusions and subocclusions in the future. That's why it's called a mini, but it's a bypass with all in all, it's a bypass. It's a modification of a bypass, but it's still a bypass. Done in same length or greater length than Roux-en-Y. Patients lose the same amount of weight. It does help with diabetes. Now, the only thing and technical thing with between the Roux-en-Y and the mini bypass is that the patient with the bypass, with the Roux-en-Y, the level of sugars go down immediately after surgery. And they still remain down after they lose weight, and then it's the weight loss that keeps them down. The mini, most of the times, is until they get the weight loss, but it's about the same thing with the sleep. Once the weight is gone, or the excess weight, the blood sugar levels will fix themselves. But it is. And regarding the mini, that's the big difference is one junction only. We just pull up a bowel and put it together with a gastric pouch. And the Roux-en-Y, we have to cut the bowel, put it together, and then technically do two junctions, or what we call anastomosis. It's a little more time consuming, so that's why the other one, especially considering patients, large BMI patients who cannot be under for a long time. All of surgeries are thought in, the gastric sleeve was born out of a two-part surgery of patients who couldn't handle the whole surgery in 2 times, or the whole surgery in 1 time. It was the idea was to do the first part and then the second one, and lo and behold, it worked as the whole surgery. So that's the mini also, trying to cut surgical times and try to, make
less exposure
to surgery and less exposure to more, more surgical time, the more possibilities of complications. So yeah, So
Lowers the risk.
and that's where the mini was born. And yeah, you can look it up now. It's mini and or single anastomosis bypass. There's several versions and they changed the name to it nowadays. So yeah, you can look it up and it will be several versions of it. So we still try not to confuse people. Just call it the mini bypass.
So then everybody's not trying to research a bunch of different
yeah,
things that are all the same.
It is confusing. I mean, even for a surgeon, it is confusing because sometimes they'll ask you, well, what is the version that you do? And yeah, some people do a different version of it. Not everybody does it the same way, so it's a different version, and they call it a different name. It's still, pretty much the same. Pretty much the same principle, but in a different version, so they will call it different. But it does help with diabetes. It does. We do both and revision. Sometimes it's not possible to do. The Roux-en-Y for some reason, another especially revision. So we go up for the mini because scar tissue, surgical times, and a lot of other things that revisions sometimes are difficult. Revisions are not always simple. People think, well, revisions will be, so it's a complex surgery that sometimes needs more time. And it's not possible to do sometimes the whole complete package of a Roux-en-Y with safely. Let's say safely. It's possible, but it's not safe for the patient, so we have to do another procedure. Yeah.
Well, I learned something new.
Yeah.
That's good to know. Keith asks, I've lost a lot of weight. It says here, also interested in plastics after weight loss. How long is good after loss? After he's had the bariatric weight loss and after he lost all the weight?
We sometimes don't see just the time, we see the weight lost.
Mm-hmm.
We see the excess weight. We see what is, some patients need it right away, even a year, and say, well, how much is he going to lose? Is he going to lose this part? Because plastic surgery, specifically for bariatrics, most of the time it's done in parts. It's not always done. Mm-hmm. So plastic surgery is a complex thing also. A lot of people think, well, I go to a plastic surgeon and I come out new. No. I mean, a plastic surgeon that does everything in one setting or one surgical time, usually it's either nuts or just playing with fire, because sometimes those surgeries are 8-10 hour surgeries, which is, for a patient, it's terrible. Yeah. The complication with those is, even if you don't think about it, it's terrible. Yeah. So it's done in time. So it depends on what you need to, and this is very personal. So if it's the arms or the legs, and they can be done at one specific time or another. On average, I would say about 1.5 years, 2 years into it. That's the most, if you feel like you're comfortable, and that's the best time to look into it and just go in.
Okay.
Roughly after 60% loss of excess weight.
And maintaining the healthy weight.
After 60%, usually, when you go over 60%, it's going to be, the patient will notice it.
Yeah. Chastity asks, I'd like to know about dumping syndrome.
All right.
How to prevent, treat, how common is it in sleeve patients or bariatric patients in general?
In sleeve patients, it's not that common. So sleeve patients still have what we call a sphincter. It's the lower sphincter of the stomach is still there. So sometimes they do have rapid emptying of the sleeve, and it could be some sort of dumping syndrome, but it's not really frequent in sleeve. Now it is frequent in any type of gastric procedure, especially bypass or single or mini bypass, whatever you want to call it. It's more common. Usually with foods with high contents of carbohydrates or sugars, that'll get it. There's early dumping syndrome. There's you have to go into those whole things, but it isn't uncommon. Usually, if you read about it, it's going to be between 2-5%. There's some books that say 10%. So it's fairly common and once a patient gets it, it'll think twice about it. A lot of surgeons will, and we have noticed that then when dumping syndrome is present for some bypass patients, they do fairly well in eating some sort of food. For example, not high starchy foods. They don't crave it anymore. They just don't want to touch it. And that is good, but the dumping syndrome is also not a good thing. So you get one with the other, but it is uncommon with the bypass. It is.
And just for some people who might not know what dumping syndrome
Okay.
is, can you explain that?
Yeah. So a patient eats. If you eat something with high contents or carbohydrates or sugars, what happens is it goes directly into the gastric pouch and then the bowel. The body detects it, or the bowel detects it, so it secretes a lot of insulin. The insulin is what helps us absorb the sugars. Because it perceives it as to be a lot because it went directly into the bowel. The body perceives it, so it throws a lot of insulin into the system. So the blood sugar goes low immediately. So that feels like you're going to pass out. You get palpitations, you get sweating, cold sweating, you feel really bad. Patient can even lose conscious out of it, so that's not a good thing. It's really, patients will feel really bad about that. So that's, in a nutshell, the dumping syndrome.
I think that's happened to me twice. Yeah, I passed out twice.
You did. Well, it could be low sugar levels
I won't be sharing that with you guys.
You already did, but
Yeah.
it could be several things. We have to. There has to be looked into. Sometimes it's not eating. That could be it also.
Yeah.
And sleep. It does happen. I'm not going to say it doesn't. It doesn't happen, but it could be something different.
By any chance, is your not intaking enough sodium can cause low blood pressure to happen?
It could happen. Low sodium could happen. Low potassium. There's several things that can happen. Sometimes it's a calcium, especially in bypass patients. Calcium, vitamin D. That happens in bypass patients, so you do have to look into it. And sleep patients, it could be the sodium, but it can be several other things. You do have to look into it when the episode happened, if you didn't eat that day.
Is it better to, Valerie asks, is it better to have VSG or gastric bypass, and what makes you a candidate for one rather than the other?
All right, so that's not a tricky question. It's a simple question, but it has a lot of answers, let's say. All right. So, depends age, BMI, comorbidities. So there's now a classification which is easily, you can put it in. So usually if your BMI is lower and you're younger and you don't have, or you had high comorbidities, and the procedure easily adjusted, we can do a sleep. But if long-term diabetic patient, sometimes we'll go for a bypass. Now, the indications are, you can Google them, they'll appear and say, this is one patient, this is the other. And then you can say, oh, I'm better candidate for the sleep of the bypass. But then again, you have to take into consideration, are you young? Are you planning on having children? Because are you planning on doing this or that? So younger patients, especially females, if they plan on having children, the bypass is a very good method of weight loss, but I don't recommend it. It has a lot of complications with pregnancies and childbirth. You can have underweight child. So it's not the best way to go. And then the complications during the pregnancy itself, you're going to get an internal hernia, you're going to get regain the weight, and then the revision of a bypass is really, it's not an easy thing. It doesn't have the same effect as a revision from a sleeve to a bypass. So I do recommend, you have to, besides what the medical norm says or the establishment said, you have to adjust to those patients. That's not always, well, I'm very candidate for a bypass. And some patients will read about it and say, yeah, I'm a very candidate, I'm a candidate for a bypass. So yeah, well, in theory you are, but we'll think about what you're going to be doing in 10 years, think about what is your life going to be in 10 years, and think about
what type of lifestyle do you think you're going to lead?
Do you really want, because, yeah, exactly, and do you want to take the supplements? I mean, because the bypass is no other way around that you have to take them. If you don't take them, you're going to do really, really badly. Yeah. There's patients who don't want to go through that, and you have to think about that. So yeah, it's easier to set. I mean, we can put it, I can bring my little paper and we can say, well, yeah, you're very candidate, because that's what the the Association for Bariatric and Metabolic Surgery says, and well, this is it. I mean, we can go with that. But most of the times we also go with the patient's needs and what the patient best interest in mind has for the next few years. A lot of it has to do also, well, especially in the U.S. with the insurance. The insurance will say, well, I only pay for one surgery, which is, I know, I mean, no one wants to pay for two surgeries, and no one wants to do two surgeries. And they usually will pay for the bypass because it is, as they call it, more definite. Yeah, it's more definite because reversibles are kind of difficult to do. But it's not, no surgery is definite surgery that you're going to lose weight and keep it off for forever. So it's not always that. So yeah, indicating, it's a difficult question, as I told you. Indicating one with another, it's difficult because you have to, pick the patient, ask the patient what the patient wants, not just what the conditions are, so you are suitable for one or the other.
Got you. That's good to know. So the next question would be, if you're having a revision from the gastric sleeve to a bypass, how much of the intestine would we be bypassing?
Okay, well, that's a very good question. So on revisions, we usually do it a little longer. When I tell you that we say between 5 and 10 feet, that's true. No, there's a lot of people who would say, well, you can bypass more than 7 feet because then all hell will break loose. There's doctors who say you bypass at least 9 or 10. So, you try to, depending on BMI, but usually we do between anywhere between 5 to 10 feet.
Okay.
7, 8 feet of bypass, that's within, and of course depends on the patient, depends on the BMI, but yeah, we do on average about 8 feet.
Okay.
Say, yeah.
That's good to know. So Sandy asks, do you look for gallstones and hiatal hernias while in there?
Yeah, I have to. Okay, so gallbladder stones are difficult and easy to see. So if a gallbladder has had an acute attack or two, you can actually see it and say, you know what, this is going to give a patient trouble, so we take it out. Sometimes the gallstones they stay there cinematic. Nobody has even seen them. There's no symptoms out of it. And when you look at the gallbladder, it doesn't even look like it has them. It looks fine. So sometimes you can't really see them, and they were already there. So it's difficult. Most of the times, if we think about it and if we have doubts, we can do an ultrasound just to make sure before surgery, or we ask the patient if we have symptoms. And because the incidence of you not having stones and getting stones after bariatric surgery ranges usually from 10 to 20%. It can be a little bit higher in some procedures, especially, for example, duodenal switch can be higher, but it's between that range. So it's a long time ago, most surgeons decided that there wasn't worth just taking out the gallbladder just because we used to do that, just take the gallbladder out. But it does serve a purpose sometimes, and we like to leave it in. So yeah, we look into that, and the hiatal hernia is really important because most of the surgeries we work up there, yeah, we do, especially in sleeves. If you have one, you repair it, and a bypass sometimes it's not repairable, or surgeons won't repair it, but most of the times we repair it. We close the screw and repair the hiatal hernia.
Okay. I still want to, this is from Angel, I still want to know, how do you feel when patients do not do the pre-op diet well? Do you know if they cheat? Can you tell? Well, what are some of the, let us know about how important the pre-op diet is.
Even for for most patients, the pre-op diet goes well with a week and a half, 2 weeks, and you can see it. For some patients, you need 3 weeks, especially higher BMIs, even 4 for higher BMIs. So even if they did the diet, you notice that didn't work that well because they're higher. Over 65 is really not their fault, but they can sometimes work on it, but it's really not their fault. But yeah, the liver's big. That's basically it. The liver's heavier, and most of the times we work with the liver. We work under the liver, so trying to retract it, it can fracture, bleed, so it's really noticeable, and it does really affect the surgical time. Yeah, you get a little mad and everything, but at the end of the day, it's the patients who gets the liver beat up a little. So, but it's your surgical time.
Could it affect recovery?
Yeah, it does. It's more painful. It bleeds more. Yeah, it does affect recovery time.
Okay, that's good to know. Stick to that pre-op diet.
Yeah,
that's very important. It's there for a reason, right?
Yeah. Okay.
A lot of people, as Jessica, Andrew, a couple other people had asked, they had heard that you possibly will be having plastic sometime in the future, and want to know if that's something still that your PA is looking into.
Oh yeah, definitely.
Okay. Yeah. I'm assuming that COVID had a lot to do with.
Oh yeah, COVID has a lot to do with a lot of things. Right.
I'm sure COVID had a lot. That Rona, she came in and was like, hold on a minute with plastic. But you heard it first that you guys are still looking into.
No, we are. But it's difficult enough without it, but right now with this whole thing happening, it's kind of tough to do it.
Yeah. Okay. So they're still looking into it. It's gonna happen at one point, guys. Gotta be a little patient. And I'm sure they're gonna let you know as soon as it's a possibility and a service that they have available. Have you ever lost a patient on the table?
No. Yeah. No, we knock on wood, but we haven't.
It's people, they wonder. They're like,
no,
I wonder.
It's a possibility. I mean, there's a lot of things. There's a lot of unknowns, and there's.
So the death toll 0 at Pompeii.
Yeah,
nice.
But there's things that, no. I'll better leave it at that.
So at the end of the day, the death toll is a 0 on death and millions on survival. So that's a wonderful thing.
That's a good thing.
You can feel easy about that.
That's a good thing, actually.
So I would just like to ask about acid reflux because a lot of people have that question.
Yeah.
Right?
Yeah, that's the thing.
And who else better than to answer that? So as far as acid reflux, Vicky wanted to know which surgery would you recommend, or if there is any difference in
all right, so
acid reflux.
It's a very
Let's
complex.
talk acid reflux.
Okay, it's a very complex.
Having it right now, I feel it.
It's a very complex question. So, bypass will take it away, but in most cases, the acid reflux is related to the weight. So usually it goes away. It gets a little worse for the first few months, and then it goes away once the patient loses weight. If a patient has a hiatal hernia, the usual pattern is to repair it, and usually that takes care of the acid reflux, and then you do a sleep, for the sleep part of it. There are patients, and what we now are calling novel acid reflux, that actually get it from the sleep. Depends on a lot of things, not just the surgery itself. It depends on how you do the curvature and the angle, technical stuff. If the emptying of the stomach it's because sometimes you take a little bit of that part of the stomach that empties itself. Most of the part is not noticeable, but in some patients that the stomach didn't empty well, it will be noticeable, and patients get reflux. And with those patients, we call it novel reflux or new reflux, because it wasn't there before. And those patients, either we treat them and see how it goes, or we try to convert those surgeries. It's not a lot of patients, really. For most patients, that's a little reflux from now and then. It gets over with, over-the-counter medication, so it's fine. But for a lot of patients, it's incapacitating. For those patients, I do recommend going to a revision surgery and doing a bypass. As still part of what we do. It is part of the surgery, unfortunately. It's part of the surgery. Technically, we try to fix it. When I say technically, is we try to see if they'll do it differently. The upper part has to be about the same diameter than the lower part. It has to be even. The funnel part, if you do it sort of in a funnel thing, patients will get a little reflux. If that curvature that the stomach does naturally, if the staples are not done correctly, if you don't put the correct staple there, you get a little stenosis there, and there could be acid reflux. So you have to know technically what to do to avoid those. And usually those will avoid the easy cases, or, those that are new and those that are untreatable, sadly we have to go to a revision surgery. But, there's surgeries to avoid it. But there's ways to avoid surgically, and we're talking about the sleep. On the other hand, the bypass really doesn't have the problem. A lot of people recommend it when you have a lot of bad reflux. But you have to look into it. Usually you have to be had an endoscopy done, or a motility of the esophagus done. Several studies that you actually know that even if you do the sleep, the reflux is not going away. Those patients are also kind of.
Oh yeah, mine is on 1,000.
You kind of know those patients,
Yeah.
and say, well, okay, so is it worth it to kind of try it? And say, yeah, okay, we'll do it. If not, we'll just recommend a bypass.
Yeah. So one of the other questions that I had was, although we always like to think of the best, there are things that can happen that that may go wrong either during surgery or afterwards, or while the patient is recovering.
Mm-hmm.
What are some of the steps that you as a surgeon would take to remedy this, that Pompeii would do to remedy these issues?
Well, same steps that they take in any hospital. I mean, it's bleeders are usually handled, if they're small, we'll handle them conservatively and just be on them for a while, non-surgical. If it looks like it's not stopping, it's surgical immediately. It's just go in and do a revision. On leaks, well, we do revisions. Revision surgery on leaks is the most important. If you go in the first 12, 24 hours afterwards, that's the best time to go in. You can actually fix them, and those patients do really, really well. I mean, if you go in within the first day or so. If you wait, if you think about it, if you don't say, well, this is not happening. So usually if we even think about a leak, or we have a doubt, even if the study is negative, we usually go in. I mean, it's not a no-brainer there. The same thing with bypasses. We try to go in as soon as possible. Why? Because things happen, and we do revisions all the time, and we do a revision on a revision, or we just go in on a surgery because it's what you're supposed to do. So in a lot of hospitals, this will get delayed. I mean, tendon is gone, and it happens to us also, but you have to come back, we have to bring the whole team, and you have to do it. And that's it, that's the bottom line. How we handle it money-wise, we'll have to ask somebody else. I don't know, but it is. So it's a little less, probably a little less expensive for us because, well, we handle those things in-house, but if you go to a big hospital, it's really expensive.
I'm sure you're
It's
going to
crazy.
get a fat bill when you wake up.
It's crazy expensive if you have to go in again. And I mean, you do everything in your power for patient not to bleed after surgery, but there's a lot of situations that can happen.
Yeah.
And no.
Okay.
But yeah, it's revision surgery immediately, or it's on top of it. Usually we don't wait for that.
Now, for sake of clarity for patients,
Yes.
there's always been those few patients that do have that mini bypass or that gastric bypass, and they still get acid reflux. Is there a difference on
That's a good
that?
question.
The difference on what?
Well, I mean, because I know there's like biliary reflux and things like that. So if someone was to have a bypass
Mhm.
and still feel like they're getting acid reflux, is there a medical explanation for that?
Especially hearing that it'll be gone after.
It usually is gone. Is it could be the first, especially if it's just the bypass is new, they can get it, especially the Roux-en-Y. If it's the mini can get biliary reflux, even though we do the length of the gastric pouch longer for that. But it's still one of the things that can happen with the mini, sadly. And with the regular bypass, those patients can actually have reflux if they have a hiatal hernia and wasn't fixed, or it was there and was unfixable. and the anastomosis is still a little bit too much, they'll get some sort of reflux. It shouldn't be acid; it should just be what they ate. But it's kind of weird that would happen to a patient with a regular bypass with a Roux-en-Y.
So it could be confusion.
Yeah, it could be
Patients
confusion.
understanding
Yeah.
if it's true. As
Yeah, it could be
versus-
confusing. Yeah,
Okay.
yeah, you have to look into it. I mean, it's
Good to
not it's not just. I mean, it could happen in both of them. It's more common in the mini than in the regular one, but it can happen in both of them. And then both of them, the patient overeats, it could, the gastric pouch is full and it will come back. And it is reflux technically, but it's you ate too much and it's coming back.
Gotcha. Well, that wraps up our segment of questions.
Okay.
I just I want to say thank you again for your time.
Oh, you're welcome.
Time is very valuable to me.
Oh, yeah.
I completely appreciate. I appreciate so much you taking your time out of your day, especially you had a long day today, to sit down with me. Is there anything at all that you'd like to close out this interview with? Just maybe a message for those who are either thinking or have had it or anything regards to a closing statement you'd like to make?
No. Thank you for coming. Thank you for interviewing me. Whoever is thinking about it, well, let us know. I ask a lot of questions, and believe me, I ask a lot of questions. That is the only way to get somewhere. Don't just hear what people say, and if they're good things and bad things, but ask a lot of questions yourself. Don't just say what the good things or the bad things people say. Ask questions yourself. That's really important. Everything is personal. It's not about. It is about following people, but be cautious and be wary of it. And ask questions. Always ask. Okay.
So that is a wrap for the questions. Thank you guys so much again for giving us so many great questions to answer. Thank you again, Dr. Quinones, for sitting with us and answering them at such an amazing capability. And I'm forever grateful for this opportunity. I hope you guys enjoyed this segment of questions with the doctors here at Pompeii. Thank you so much for following, liking, subscribing, and being a part of my journey. Have a wonderful night. Thank you very much. Muchas gracias, everyone. Bye.